Hello, I'm Mark Freeman. I'm medical director for the service line of orthopedic surgery at Erlanger Health System and also an assistant professor in the University of Tennessee College of Medicine. And today I would like to talk with you and share with you my thoughts about humanity versus technology. I'm an orthopedic surgeon, so obviously this involves orthopedic surgery, but also in general medicine in the 21st century. Erlanger's motto is "We compassionately care for people." Indeed, I saw this quote when doing some research for the talk that we're all physicians. It's a proud title. It carries prerogatives. It carries privileges. Most of all, it carries accountability and/or responsibility, not only for the future of a great profession, but for the very lives of our fellow sufferers from the human condition. And this was written almost 100 years ago, and I think it's as true today as it was then. The practice of medicine is the noble profession, right? It's an art, not just a trade, a calling in which your heart will be exercised equally with your head, said Sir William Osler. And indeed, isn't it the practice of medicine? Do we not get asked for our medical opinion? And we all know that medicine and patients do not always follow the rules or follow the textbooks. Traditional medicine is based on history and exam and diagnosis. It's based on listening to patients, looking, palpating, examining patients, and then thinking about the differential diagnoses. And then through our knowledge, our experience, and oftentimes the intangible things such as empathy, we tend to execute treatment options and plans and then evaluate our outcomes and change for that patient or for future patients accordingly. Again, the art of medicine is loved. Then there's this love of humanity. And what is more human than humans taking care of humans? At the same time, though, there's an evolution. And one thing is inevitable in life is that change is inevitable. Whether it's humans and human beings and patients, whether it's viruses that we've seen over the past year with mutant strains of COVID, whether it's the environment and climate change, whether you believe in it a little or a lot, and then certainly diagnoses and treatment algorithms in medicine have changed dramatically over the centuries. And so if we do not keep up with and embrace change, in particular technological advances, we as individual physicians and as a group of physicians in our whole profession, we will be left behind. I utilize the car as an example. And so I was thinking about this talk and technology, and as technology has progressed in orthopedics and all of medicine, just 100 years ago, if you think about a car and how you started a car was with a crankshaft. Few people even remember these cars. I'm sure there are plenty of people in the audience on this Zoom chat who don't even remember how to start a car with keys. Because these days you push buttons and you have key fobs. And then now we've gone to where you can start your car with a remote control app from your phone. And who would have thought about this just 100 years ago? The same thing where you don't even need gas pedals. You can electronically change the acceleration or deceleration of your car. Who needs to learn how to parallel park anymore, because now your car will park for itself. And then does anybody remember a stick shift like this? Well, then there's the manual transmission of just 20 or 30 years ago, and then the automatics. But then what was released last week is Tesla's now going to allow us to change the gear of our transmission via the touchscreen. And I'm not sure that even though we can do this, we should do this. There are other traditional industries where things have gone from old technology to new, whether it's handmade things in manufacturing to human assembly lines to robots, from boats to planes, from site control and stars to instrument ratings and autopilots. And so it reminds me of a quote that I ran across again, that without technology, humanity has no future, but we have to be very careful that we don't become so mechanized that we lose our human feelings. Technology in medicine is no different than other industries. Before we are even born, we now have 3D ultrasounds, genetic testing, amniocentesis, even fetal surgery. As kids now, we have cochlear implants, craniofacial surgery, prosthetics for amputees. We now have, as adults, drugs, pacemakers, interventional radiology, joint replacements. And then towards the end of life, we have transplant surgeries, trauma care, cancer. The list goes on. Before COVID, this was a trend that technology was emphasized over humanity. After COVID, exponential growth, and more importantly, acceptance, not just from patients and providers, but now insurers and payers. And my recommendation is be aware. Telemedicine's great. I have no problems with telemedicine. Certainly through last year, it helped us take care of patients when we couldn't do it in the old traditional ways. But reliance on labs or imaging or tests without the rest of traditional medicine, such as the interaction of listening, of palpating or examining, and of thinking, may get us in trouble. It reminds me again of a quote from the past. Years ago, Albert Einstein, that it's become appallingly obvious that our technology has exceeded our humanity. I hope that someday our humanity might yet again surpass our technology. Is this a healthy competition? If you think about nurses, bedside care of old versus now the time spent EMR charting. What about physical therapists? Hands-on therapy was the mainstay years ago, and now you have equipment and modalities and the pressure to see multiple patients at once. What about pharmacy? From the personal interaction, my father was a pharmacist, my grandfather was a pharmacist, and now much of that expertise is now computer database and computer log entry and oversight. Bedside physicians, bedside engagement. Now it's telemed and tech driven. And then in surgery specifically, the art, the experience, the judgment of the established surgeon now being supplanted or overrun by technology and even robotics. In terms of orthopedics, we're a very technology-heavy discipline. Orthopedics is not as new as what many people think in terms of a medical discipline. The ancients described injury descriptions and treatments. The Greeks and Romans had systematic study of musculoskeletal diseases. And even in the Renaissance, there were detailed anatomy, even Leonardo da Vinci and others describing the anatomic detail of the musculoskeletal system significantly. But the modern father of orthopedic surgery is known as Nicholas Andri. And in the mid-18th century, he wrote The Art of Correcting and Preventing Deformities in Children. And the frontispiece for that book is seen below is the crooked tree, and then the stake, and the basically guiding the growth of the tree to straighten out deformities. And so ortho means straight, pedic means pediatric, and so there the name of orthopedics was born. He also was instrumental in creating separate orthopedic hospitals for the care of large populations of orthopedic patients. It's interesting, though, that the evolution took 100 years before the procedural paradigm change. In the 19th century, who could imagine procedures done before ether anesthesia, cast to hold your reductions, Lister is the father of antiseptic wound treatment, and then even x-rays were not developed until 1896. In terms of the 20th century, the world wars contributed significantly to technological evolution, from World War I with traction to World War II for intramedullary nailing of fractures in military, and then joint replacement from the 60s, large open surgeries, to then sports medicine and arthroscopy and the minimally invasive surgery boom of the 70s through 2000. Ever since, exponential growth and technological advancements, not just in all of medicine, not just in other industries, but in orthopedic surgery specifically, with materials, designs, devices, and techniques being very difficult to keep track of. This is the curve for the rest of technology, and orthopedic surgery is no different. Over hundreds of years, you see a relatively flat curve, and only in the last 50 to 75 years, exponential growth and technology innovation. So the 21st century, technology in general, it's exciting, it's fascinating, but as physicians trying to take care of our fellow man, it's overwhelming sometimes. It affects all aspects of medicine and the patient care process, from patient access to imaging and diagnosis, to surgical planning, to surgical execution, to the actual implants and devices we use during surgery, and then frankly, the outcomes and follow-up, and then teaching of the next generation of surgeons. Patient access, internet search, ratings. You can't see a patient in the office today without them having done their research. The EMR, Epic, and MyChart that Erlanger has been a large boon, but also a large burden for many practitioners trying to take care of their patients. And certainly the Internet Doctor of Medicine degree that many of our patients and family members have makes you sometimes want to say, please don't confuse your Google search with our medical degrees. At the same time, this is a double-edged sword, right? It's a blessing and a curse. We want our patients to be educated. We want them to come in and be knowledgeable and ask articulate questions. But it seems I spend an inordinate amount of time now trying to figure out what information they've obtained is good and what is inaccurate or not applicable. What about imaging and diagnosis? From the old X-ray, analog X-rays of 1896, now to digital X-rays and PACS, and X-rays can be sent around the world or to your mobile device to be reviewed. We have CT scans, whether it's soft tissue organs to the musculoskeletal system that now can be seen with 3D reconstructions. We have Mars protocol, metal, artifact reduction software protocols that now MRIs can be used to look at joints around devices that are metal that are implanted that in the past would have caused artifact. Indium scans, Synovusure, new ways to look at infection. And then EOS, Erlanger is the only hospital in the region that has the ability with low dose radiation to take standing and sitting full body skeletal films and then 3D model patients for deformities, whether scoliosis in children and adults, long bone deformities, leg length inequalities, or in my field, joint replacement surgery, such that now you can take patients who have the hip spine syndrome, which is now being reported extensively in the literature. We can look at how patients' functional activity from sitting to standing affects their back, their hips, joint replacements, degenerative arthritis of the back, spine fusions, and other things to improve their balance, their gait, and potentially decrease the risk of complications such as dislocations. What about surgical planning? My partners and I at Erlanger use TraumaCAD. We take hip or knee x-rays or shoulder x-rays and can plan ahead the specific devices that we wish to use, sizes, angles of instrumentation and alignment, and then execute that during surgery. We can create 3D printed models ahead of time. So if I have a patient who's had severe bone loss, whether from trauma or prior surgeries, instead of making decisions on the go in the surgery, I can 3D print a model, make custom implants, plan the surgery ahead of time without anesthesia risk, blood loss, and make the surgery far more efficient. Now we can even plan and do patient-specific instrumentation that's custom for them, or even custom implants. At Erlanger, we do custom knee and hip replacements, one of the few hospitals in the region to do so. What about surgical execution? Now we have intraoperative imaging. We don't just rely on x-rays before surgery. We have fluoroscopy or intraoperative CT scans, such as the Arrow or Zeem. We have minimally invasive guides, whether it's for fracture care or for joint replacement or sports procedures. We now can make the same surgeries happen through smaller incisions with special instrumentation. We now can do deformity correction. We have some partners who now do deformity correction in kids or adults with computer-guided external fixators called the Taylor spatial frame. I use a different cautery device. We have new drugs such as tranexamic acid over the past 10 years. Again, patient-specific instruments. So instead of 15 trays of stainless instruments, we now can 3D print custom instruments that fit that particular patient's anatomy, that are disposable, and then after surgery get thrown away. Computer navigation. We now have devices during surgery that are similar to your iPhone that can have an accelerometer or gyroscope to plan surgery, mapping out angles and resection levels for orthopedic surgery during the surgery. Again, as disposable devices that are far more accurate than the analog instruments of 20 or 30 years ago. And then I'd be remiss not to say, in the past year at Erlanger, we've attained 2 robotic-assisted surgery systems for joint replacement. So only Erlanger has multiple platforms, and it allows us as the surgeons to have increased flexibility, offer more choice for patients, and hopefully improve quality both during the surgery and quality outcomes afterwards. And we're still collecting data on that. What about implants and devices? One of the huge revolutions in fracture care in the past 30 years has been locking screws. And so rather than just regular screws that provide compression to the bone, now we have locking screws that have differential threads that lock into the plate. And with the osteoporosis epidemic that we're seeing in the United States, this has allowed us to fix fractures far more easily and/or reliably in the osteoporotic population. Who would have thought 20 years ago you'd almost have to have a material science degree to be an orthopedic surgeon? Between the bearing materials we use, ceramics, metals, cross-linked plastics, uh, multiple different bearing surfaces for different patients and different indications. Who would have thought the orthopedic surgeon cares about histology? The biologic ingrowth and ongrowth of bone is variable in different patients on different medications with different joints, different fractures, different metals, different surfaces, and different surgeries that we do. We have to keep on top of this, and it changes on a yearly, if not faster basis. Then there's custom 3D printed materials. So not just 3D printed instrumentation, they're now 3D printed implants that we can use, custom made for each patient. And certainly now we're going to start seeing 3D printed exoskeletons and braces so that we can fit that child or that adult after an injury with a better splint, more custom, and also easier to take care of, clean, and potentially even swim and bathe in. What about outcomes and follow-up? Erlanger is one of the few in the region during COVID when there was a no visitor policy to try to continue to have great patient and patient family communication. EASE is a platform we're trialing to help when visitors are not allowed in the hospital or when patients have family members that are out of town who are unavailable to come to Chattanooga to reach out and have communication with the nursing staff and physicians to keep in touch with their loved ones during surgery and afterwards. What about data for surgery? We're a participant in the American Joint Replacement Registry and truly look at that data and look at outcomes and try to make cost-effective decisions for the good implants, the bad implants, which ones to use, which ones not. We also are the only hospital to use CareSense for our musculoskeletal patients. This is a platform for surgery patients in orthopedics that they get a communication platform with text alerts and reminders and educational materials before surgery for pre-admission testing, the day of surgery, and then post-operative surveillance, whether therapists or nurses or our nurse navigators reach out to patients through this portal. And we also collect scores, outcome scores that have been validated to assess their post-operative objective and subjective performance. And then fortunately, in the past several years, we've been rewarded by doing this. That shows our patients actually start off with worse physical and mental health scores before orthopedic surgery and actually end up with better scores than the national and regional averages. What about teaching in the future? There's virtual reality, and now virtual reality is almost obsolete, even though it just got started several years ago. And now we're in augmented reality, where now we can actually visually see projected images of surgical operations while you're doing the operation. This will be the new mode for teaching resident surgeons and medical students in the future. And my hope is orthopedic surgery is going to be a leader in the medical discipline for this. And there's already much research, much vendor involvement, and medical schools and residency programs across the country getting involved. The last thing to talk about is artificial intelligence. It's the wave of the future, and we have to be very careful so that we can use, again, our humanity, but also the technology of the future that's being used in other disciplines to monitor data, to monitor our outcomes, and help teach us how to be better surgeons and physicians. So going back to our mission, our focus must be compassionate care. Technology is inevitable, change is inevitable, but we need to use it as an augmentation, an adjuvant, a synergy, if you will, that it's only tools in the toolbox. We still need to be physicians, we still need to listen, we still need to examine, we still need to think, and we still need to treat, utilizing the art and skills of the diagnosis and treatment that we've been mentored and learned as experienced physicians. And again, be reminded that medicine's not just a science, but it's an art. And that perhaps the character of we as physicians may act more powerfully for the patient's good and outcome than the drugs or treatments or technology that we use. So indeed, the good physician treats the disease, but the great physician treats the patient who has the disease. So what is my vision for the future? A synergy of the old traditional medicine with the new cutting edge. Again, technology and change is not always growth. It's just as movement is not always progress. We cannot live solely in the past as historical physicians, but we need to be very careful about the future. We need to keep our humanity switch on. We need to recognize that humanity and technology are converging, and we need to be the ones who usher us into the next generation or the next century of medical care. I'm proud to be a part of Erlanger Orthopedics and would say that we are a comprehensive orthopedic program. We have over 20 physicians and 9 APPs who care about the human aspect of taking compassionate care of people, but who keep up with the state-of-the-art technology to improve the outcomes of our patients, whether through surgery or non-operative means or therapy or bracing or education. We're the best care for the common musculoskeletal issues, but also for the worst of the worst. We have walk-in clinics to comprehensive tertiary referral centers for most musculoskeletal problems. Again, I'm proud to be a part of the Erlanger Orthopedic Institute and would take any questions. Hi there. So I have a question that says, do we believe that we're far from all components for a patient surgery being 3D printed to their specific anatomy, regardless of the surgery type? I think we're already there with the technology to be able to make implants. Whether it's going to be all patients, probably not, due to manufacturing issues and time, but certainly in the next 5 to 10 years, I think patient-specific and 3D printed additive manufacturing, if you will, is going to become more and more common across all disciplines, no question. And this is not just for bones or for metal implants, but for those in the other fields, that biologic tissue engineering and 3D printed scaffolds to grow human cells and grow organs in the future, obviously from a non-orthopedic perspective. So I don't think we're far. Not sure that it will 100% overtake our disciplines and our careers, but certainly that's the future. It's fascinating to try to continue to improve the art of medicine, but also keep up with technology. And you keep up with technology and learn some skill sets, and then the very next 6 months or a year, you're learning others. And the outcome evaluation is critically important, not just for the diagnosis and treatment outcomes for patients, but also attempting to evaluate the execution and technology to see whether the learning curves are worth trying, to see whether the new tools and instruments are worth risk. There are always advantages and disadvantages of trialing new technology. And certainly it's important to try new things, but also, as many have said, being the first to do things is not always the best, but you certainly don't want to be the last. I appreciate the invitation from Dr. Maniam and Dr. Jackson and be a part of the Erlanger Symposium. And certainly any questions, please reach out to Chris Werner, our Orthopedic Service Line Administrator, or to me, or any of your orthopedic colleagues in the community. We're happy to assist. Enjoy the rest of the symposium today, and have a great weekend.